Hello, everybody. Good morning, good afternoon, good day to you, wherever you are in the world. And a very warm welcome on behalf of IPC Partners, the Healthcare Infection Society, and the Infection Prevention Society to our Insight webinar, all about Candidozyma auris and the infection control challenges in Kuwait. I'm delighted to be joined by Dr. Areej Alali and also Phil. So, Areej, could you introduce yourself?
So thank you very much, John. Hello, everyone. Happy New Year. My name is Areej, and I'm a medical doctor with a PhD in epidemiology and public health from the UCL UK. And currently, I'm working at the Infection Control Directorate in Kuwait as a head of the surveillance department. And I am an epidemiologist, as I mentioned. My interest is in the outbreak management, healthcare-associated infection, as well as automation of healthcare-associated infection. So is that enough, John, or?
Perfect. No, exactly. Yeah, exactly right. And Phil, I mean, do you even need to introduce yourself?
Hopefully they know we come as a double act. But for anybody who's joining IPC Partners, our webinar for the first time, my name's Phil. I'm currently leading a program of research at the University of Sussex around IPC and sustainability. I'm a microbiologist by background, and I've been working in IPC for the last 15 years.
And I work in IPC at Guy's and Tommy's in London, and delighted to be here today to talk about Candidozyma auris. Before we do, though, I just thought we might throw something around before we get going into the auris detail. And I'm conscious that Areej, you're working in Kuwait, in the Middle East, in a very different healthcare system to me in London, which will be different to other people joining from other parts of the world. So I was just wondering that since it's the start of a new year, what would you say is the biggest challenge that you're facing during 2026 from an IPC point of view?
So the biggest challenge from IPC point of view is the yeast, the shift from bacteremia to candidemia. I think this is one of the biggest challenge nowadays we're facing. Add to it the residual of the post-COVID era, which is the nurses-patient ratio, the lack of the shortage of the specialized nurse, especially in the NICU field, and the spread of infection that tripled or more post-COVID until now. But I think that if you will ask any IPC member nowadays, what is your biggest challenge? I think the majority will reply the candidemia, yeast, as well as stewardship programs.
Interesting. Okay, so you're now seeing auris as the single biggest challenge facing the healthcare organization from an IPC point of view.
Yes, I think that the Candida now is one of the biggest challenges we're facing, not only regional, I think regional and also international.
Okay, thank you. That's really helpful and salutary, actually, for those of us who don't often see auris at the moment, which is the case in the UK at the moment. Phil, what's your biggest challenge for 26?
Saving the planet, isn't it? With my new job. I mean, it's a really difficult question. I think AMR always comes to the front of my mind, emerging MDROs. But my personal kind of challenge for this year is to try and think about how we can make healthcare more sustainable. Doing some really exciting work looking about new decontamination methods and how we can potentially go from single-use to reusable medical products to kind of impact the big carbon footprint that healthcare has in the UK.
Okay, great. And then from my point of view, it's hard to pick a single thing, but I think if I was to pick one thing, the biggest challenge, it would be changing human behavior. If we can crack how to effectively change human behavior and get people to prioritize sensibly from an infection control and point of view and practice safe behaviors, then we do a lot better on all kinds of fronts when it came to infection prevention control. We'd have a safer system of healthcare for sure. Okay, so just before we hand over to Areej to tell us about auris in Kuwait, just a little bit of background on these Insight webinars. This is actually the first one. We've got a series of 11 lined up for the rest of 2026, covering key areas in infection prevention control, healthcare-associated infection, and AMR. So what are we trying to do? We're trying to provide a concise expert overview of a relevant topic. Today it's auris. We want to generate discussion, so please do put questions into the Q&A box what we tend to find is they all come flooding in at the end of the session and we get overwhelmed and can't read them properly. So do please pop questions into the Q&A as they occur during the presentation. It's an opportunity for CPD. This event is accredited for 1 point, CPD point by the Royal College of Pathologists. We want to exercise critical thinking skills and not just take evidence and research at face value, but really ask the questions to get under the bonnet of these issues. We're keen to build confidence for your independent study so you can go away from here feeling empowered to do some independent learning. We're keen to foster a network of enthusiasts. We love what we do. We hope that comes across and we hope that you do too. And to the extent possible, in a subject that may be seen as a bit dry by some people, we want to have a bit of fun. Just to let everybody know, this event is recorded and will be available on the IPC Partners YouTube channel after the event. So without further ado then, I'm going to stop sharing my slides and hand over to Areej to tell us about C. auris in Kuwait. So Areej, over to you. Areej.
Okay, so thank you very much, John, for this opportunity in presenting over the coming 30 minutes. And today, as I mentioned just like a couple of minutes back, that I will talk about the major threat in Kuwait, which is the C. auris, because I will not call it Candida auris anymore. So it's the C. auris as an infection control challenge in Kuwait. So next, please. So C. auris is recognized as an urgent threat by the CDC in 2019 and as a critical human fungal pathogen designated by the WHO. Next. And why C. auris is considered a huge challenge to the healthcare system? Because since the start of the discovery of the C. auris in Japan in 2009, it has rapidly spread across more than 45 countries in 6 continents, as well as it has been subdivided into 5 clades with distinct geographical distributions. So if I will talk about the burden of C. auris in the country, so just allow me to talk very briefly in Kuwait that since 2016, we started to implement and apply the US CDC in order to diagnose and report healthcare-associated infection in both critical and non-critical area in the country. And if I will look at the most updated data in 2024, out of all healthcare-associated infection acquired in the adult medical surgical ICUs, half of those infections were a primary bloodstream infection. And if I will look closely on the primary bloodstream infection, next, I will find that almost 2/3 of those primary bloodstream infection, which is 66% of my primary bloodstream infection, among the adult surgical medical ICUs were central line associated bloodstream infection. And if I will look at the distribution, the microbial distribution among the CLABSI cases reported in 2024, I can find that almost 50% of those microbes attributed to CLABSI, next, are the yeast or are the Candida species. And if I will dig more to look at the growth trajectory of the candidemia in the country since 2016 until 2024, I found that the candidemia trajectory is having an ascending trajectory, increasing pattern over the years from 2016 until 2024. And if I will dig more to stratify the different Candida species attributed to the candidemia that reported as HAI bloodstream infection, this graph is showing 4 different trajectories with 4 different colors. So representing different species, albicans, parapsilosis, tropicalis, and auris. So the yellow trajectory is the auris, and I think it's very obvious in 2024 there is a huge gap between the candidemia due to C. auris compared to the rest of the species. Next. More, in addition, almost 1/3 of my CLABSIs reported in 2024 at national level among adult medical surgical ICUs were attributed to C. auris compared to less than 10% in 2022. So as those slides or data showed the burden of C. auris in the country being the biggest challenge and the biggest part of the CLABSIs reported, and as the CLABSI reported represent almost 2/3 of my BSIs in the ICUs. So we've decided to start the National CLABSI Reduction Strategy in 2024, which will include all adult medical surgical ICUs in the country on a time series pattern. And just to give you a brief introduction, we have 7 general hospitals in Kuwait, covered 12 medical surgical ICUs, that includes 231 ICU beds. And to talk very briefly about the healthcare system in Kuwait. So the healthcare system in Kuwait, we have 7 governorate, and among those 7 governorate, each governorate has one general hospital with a couple of number of polyclinics, and each general hospital has a certain number of ICU, medical surgical ICU, with a certain number of beds, and each general hospital is taking cared by a team of infection control that includes a doctor as well as a nurse. And the Infection Control Directorate, which is the central directorate, is responsible of all the infection control team offices that is located in each of the general hospital in the 7 directorate in order to implement the infection control measures and the recent most updated policies and guidelines. So in Kuwait here, we're different than the UK or other countries. It is not as each trust or each hospital will work independently. All the hospitals under the state of Kuwait and MOH Ministry of Health will be under the Infection Control Directorate as a central directorate. Next. Yes, next. So the CLABSI reduction strategy started in 2024, as I mentioned earlier. And in January 2024, we started to enhance the leadership. Next, John, we started to enhance the leadership and to increase the awareness and support. And after that, we chose champions, and those champions were our ICU nurses, the frontliners. And we trained those ICU nurses, we educated them, and we had like extensive meetings with those ICU champions to understand their gaps, their threats and challenges, and to know why the CLABSI rate is increasing in the country and not decreasing, especially post-COVID era. And we enhanced training, on-site training, workshop training, and many training, like different training tools were used in order to apply the bundle of care of CLABSI reduction that is known in the literature and try to minimize or reduce the risk of CLABSI. Also, during this time period, we work on digitizing our HAI surveillance, as well as we had a constant contact with the central medical store to make sure that the supplies are available to the hospitals in order to apply the bundle of care. So after 2024, we went back to our data in order to understand did it work or not, because if you cannot measure it, you cannot improve it, as they say. So next, John. So if you look at your data in 2023 compared to 2024, I don't think you can find any decrease or increase in the trend, where the growth trajectory of the CLABSI is going up and down over the 2 years with no sustained decrease or increase. And this is how it's shown. On the other hand, we found that the Candida auris acquisition rate is increasing. So next, if you will look at 2024 compared to 2023, so the C. auris acquisition was increasing in 2024 compared to 2023. And here, I would like also to clarify a point that some hospital might not have that burden of Candida auris or C. auris, not because it's not there, because in Kuwait, we do extensive active screening. We screen every single patient admit to our ICU at the level of the country. So among all our medical surgical ICUs in Kuwait, the adult medical surgical ICU, we screen standard screening every single patient admitted to the ICU, no matter of his background, medical diagnosis, age, or infectious status. And not only this, we screen them periodically every 7 days. And also, if they did not complete those 7 days on discharge or transfer to any other location. So each patient will have a couple of screening surveillance samples that will be taken from him on admission, during admission, and on discharge. Next. And we found that the standard traditional infection control measures, the bundle of care that is well known in the literature, that used to work with Acinetobacter, with gram-negatives, Klebsiella, Pseudomonas, it's not anymore working with yeast, specifically C. auris. And we started to go over all the gap analysis that we did with our nurses and champions as well to understand what are the threats or challenges that we're facing that prevent the C. auris reduction. And C. auris, by its nature, it has many challenges. First of all, it causes invasive candidiasis. Whenever it will reach the blood, it's a problem. It is an intrinsically resistant to antifungal, as well as there are many issues related to lab identification. Moreover, it contaminates the surfaces with environmental resilience, and it colonizes the patient's skin. So in the coming slides, I will go over all the challenges that we faced regarding the C. auris, and I will also come with solutions that how did we overcome those challenges that we're facing. Next. So the first challenge that we were facing is that it causes invasive candidiasis. You all know that any Candida species, either auris or other, it can invade the sterile area of the body, mainly and mostly candidemia. And whenever we're having a candidemia, the mortality rate will exceed 40%. And according to the latest data by the ID Week in the United States, they showed that 3% of the candidemia patient with candidemia will result in irreversible blindness. That's why here in Kuwait, in our ICUs, patients with candidemia, we will always consult ophthalmology to make sure that this blindness is not an irreversible damage. And not only this, the issue or the problem with the auris, that it will start as a silent carrier. And as I mentioned, if you will not screen, you will never know your problem. So in 2022, during or post-COVID era, when we started to face those positive surveillance sites or positive screening samples, the majority of those screening positive were only axilla groin nasal, and there was no any blood infection associated with those C. auris. So the biggest argument at the beginning with the ICU stakeholders or the healthcare worker, that we're having here C. auris because we're screening for C. auris. If we're not screening to C. auris, we will never have any problem. Stop screening, so our problem will be released. But over time, as it's shown in this epi curve, the blue bar is reflecting the skin colonizers, and the red bar is reflecting the candidemia with C. auris. So over years, the percentage or the proportion of candidemia due to C. auris, BSI, C. auris out of the total colonizer is increasing. And it turned from a silent threat into a very obvious major threat in the country. Next. This is showing how the number of bloodstream infection is increasing over years, 2024 compared to 2023, compared to 2022. The second challenge is that these C. auris are intrinsically resistant to fluconazole. And not only this, they have the ability to mutate further and acquire resistance to other different antifungal, leading to treatment failure. So this graph is just representing one center in Kuwait. It's not a national level. It's showing that it has two colors, the orange and the blue. The blue is reflecting the candidemia attributed to C. auris, that is amphotericin B sensitive. And the orange one is the candidemia due to C. auris, that is amphotericin B resistant. So over years, since January 2023 until October 2024, the orange color is overcoming the blue color, which means that the resistance among the C. auris in the blood is not only at the level of the fluconazole, it is exceeding also to be resistant to amphotericin B. Next. And in 2024, more than 50% of the bloodstream infection due to C. auris were amphotericin B resistant in that center, compared to 20% in 2023. So even over year, the percentage of the amphotericin B resistant out of BSIs due to C. auris in one center in Kuwait is doubling that in the previous year. And this line list is just giving you an example, like how the amphotericin B resistant is very fatal because it is resistant to antifungal. It will end up with a treatment failure. And as per the CDC criteria, if the same bug is continued to appear in the blood after 14 days, you will report another eclampsia on the top of the first one. So this line list reflects different colors, blue, pink, and green, which reflects a patient. So the green color is a patient who reported to have 4 eclampsies because he had a C. auris and Vitersen B resistant in the blood, and no matter the antifungal treatment that he received, it ended up with a treatment failure, and the patient kept showing the C. auris in his blood until he passed away. This just to reflect one of the challenges of the C. auris, that sometimes it's not how many patients with Candida, with eclampsy, it is even within the same patients, you will report more and more infection just because of the treatment failure. Next. So the third challenge that I would like also to go over is the misidentification by the lab. So the lab misidentifies some of the C. auris as other yeast, and this will lead by undetecting silent carriers, colonizers, that they don't have sign and symptoms, especially if you are not doing active screening. And as more silent carriers you have, because of misdetection, you will have more transmission between your patients and more outbreak in your locations. And even if you're screening, even if you have an active screening for your C. auris on admission, periodically, on discharge, still there are many challenges. Are you doing cultures or PCR? PCR is more sensitive. It takes less time. So you will know your silent carrier quicker. However, cultures, sometimes it takes 5 days. So those silent carriers will be undetected until 5 days, until the culture will be released. So more chance for transmission and more chance of spreading of the C. auris. And we all know, I think it's not only here in Kuwait, everywhere, the majority of the staff will only apply strict isolation precaution once the culture is released and once the patient is confirmed for that bug. And no matter how many suggestions you will give them to keep the patient under isolation until the result will be released, especially if it is for screening, still the staff will not be that compliant to the PPE and isolation precaution until the result will be released. So the time difference in the release of the result is a major issue. And even if you're doing the PCR that is more sensitive, faster, still where you will check, where you will cite. The site of sampling is very important. Is it groin? Is it axilla? Is it nose? Or its hands? Next. So one of the most recent literature that was published by Susan Huang team in 2024, they were looking at different sites to screen for Candida auris. And they found that there are 5 major sites that people screen. They use to screen for C. auris, which is the nasal, groin, hands and palms, axilla. And this paper was showing, if I will use one body site, which body site will be most effective to detect C. auris? And if I will use more than one body site, how many body sites I need to maximize my detection to the C. auris? And which of those is available, and which lab in which country have enough resources to screen 5 different body sites for each single patient admitted to the ICU, and then periodically, and then on discharge. So this is also another challenge, because if you're screening axilla groin, you will miss the hands and palms. And this table showing that hand and palms among the one body site has the highest number of C. auris detected. If you're only doing hand and palm and neglecting the others, you will also miss other C. auris. So this is another challenge, which is very debatable, which site you will screen and how many sites you will screen. Next. And one of the unpublished data, this data is still unpublished, they found that 20% of the positive cases, they were only positive on hands. So if you are screening axilla, groin, nose, and you're leaving the hands of the patients, you might miss a good proportion of your C. auris, keeping more silent carriers. So why active screening is very important? Why the method of active screening, the sites of active screening, very important? Because C. auris colonize the skin, and once it will colonize the skin, it has a very high shedding rates. So C. auris usually it colonizes the skin including the hair follicle through a process called fungal adhesion service colonization factor. It's like a glue that will help the C. auris to stick to the skin and hair follicles. And not only this, also whenever it will be exposed to sweat, it will also allow the C. auris to form a multi-layer surrounding the C. auris, which is the biofilm. And whenever C. auris will be surrounded by biofilm, it will also affect the colonization, the decolonization, and also the detection. Next. So another challenge beside the lab, the colonization, and the invasive candidiasis with the multi-antifungal resistant, I think the environment is one of the most important things that we should think of whenever we would like to eradicate C. auris, because C. auris can survive on hard surfaces, even in a dry condition for weeks and weeks and weeks. And the majority of the hospital antiseptic used, which is the quat ammonia or alcohol, whatever, or the medium level disinfectant, they are unable to penetrate the biofilms of the Candida auris and kill the Candida auris. So no matter how many times the nurse in the ICU is disinfecting the services and the medical devices, if that disinfectant was not sporicidal, it was not a high-level disinfectant that can penetrate the biofilm, all the effort that the staff is putting to disinfect the services and the medical devices will not end up with a good result. And the problem with the high-level disinfectant, the sporicidal, that can penetrate the biofilm, that it is invasive, it is corrosive, it can damage the expensive medical equipment in the ICU room, as well as it can cause irritation, allergy to the staff and the nurses. So during the 2024 gap analysis year, when we found that no matter how many quat ammonia disinfectant or alcohol was applied on the surfaces to be disinfected, we found that it didn't have any effect. And the same room, whenever any new patient will be admitted to that room, he will get the same bug or the same C. auris. So we turned from the low-level disinfectant into a high-level disinfectant. And the only disinfectant we had at that time was the chlorine tablet. And that was another challenge. Chlorine tablet, first of all, it is very corrosive and it stained the equipment as it's showing in this photo. Next. It requires a manual preparation, and not only it requires manual preparation, in order to dilute the chlorine tablet, it is unknown which concentration is effective to eradicate the C. auris. Is it 500? Is it 1,000? Is it 5,000? Is it 10,000? So during that stage, we're following an expert suggestions in the United States, some of the centers in the United States where they were able to eradicate the C. auris using more than 5,000 ppm, which is a very high concentration that can stain and damage the devices very easily. Moreover, it doesn't act on dirt. So this is another load that the nurses should clean all the devices and services and then disinfect, because the chlorine tablet, it does not act on dirty condition and dirt can deactivate it easily. So now, after going all the challenges and threats that we had in 2024, and after all this brainstorming, understanding our problem with the antiseptic, skin colonization screening, our invasive and the invasive candidiasis and antifungal data. So in 2025, next, we decided to change our plan, and if we will keep doing what we used to keep to combat the gram-negative, we will end up having no improvement or no change in the result, because it was very clear to us that eradicating Acinetobacter or Klebsiella or Pseudomonas is way different than eradicating the C. auris. So we've decided to change our traditional infection control measures and to be more aggressive towards this C. auris. So what happened in 2025? Next. So if it will go to the diagnostic issues and challenges, we were very glad to say that we standardized all our screening method. So all our ICUs now, adult medical ICUs in our general hospital, they screen on admission on weekly basis as on discharge. At the start in 2024, we found some differences. All of them will screen on admission. However, some will screen on 7th day, some will screen only on discharge, some will miss the discharge. So we made it very clear, we made it standardized, so the comparison can be made very clear that all the ICUs, all the patients in those ICUs will be universally screened on admission weekly basis, on discharge and transfer. And also half of our ICUs now, they shifted from the culture to the PCR in order to make the release of the result quicker, and thus identifying the silent carrier is easier. Next. Regarding the environmental cleaning and disinfecting, so we shifted from the chlorine tab, which we found very corrosive, very time consuming, into a waterless wipes, which is the parasitic acid wipe. And we found it very practical. It doesn't require pre-cleaning. It works on dirty condition, and there is no manual preparation. It will be activated on time, and it's near neutral and typically set at around a pH of 8.5, which is way better than the parasitic acid solution, which is more acidic, more corrosive to the devices. So the use of those high disinfectant wipes instead of the chlorine bleach tablet made a huge improvement in the environmental cleaning, with less negative impact on our devices, and less effort on the nurse, as she doesn't need to clean and then disinfect, dilute, use bucket, use cloth, and environmental cleaning was more encouraged. And not only this, we also started to monitor the effectiveness of a cleaning by using those fluorescent gel with the UV light. So our infection control nurse will go during the shift and will add all those fluorescent gel on the devices, especially the highly touched device like the infusion pump, the syringe pump, and the monitor. And the next day he will come with the UV light and will detect all those areas were missed. And the net of this is not to just blame them or point fingers, is to give them a prompt feedback, so that nurse who missed that cleaning in the previous shift will be contacted on time and will be informed about the area that was dirty even after his cleaning, in order to raise his awareness and improve his compliance. Next. And regarding the skin colonization, if I will ask any nurse in my country or even other country, how do you bathe your patient every day? So the answer will be with 2% chlorhexidine. However, it's not only about 2% chlorhexidine, it's how to apply the 2% chlorhexidine. The method of application, it's not the 2% chlorhexidine that is being used. How are you applying the 2% chlorhexidine to decolonize your patient? So we had a visit by Susan Huang, who's the leader in the field of the RCTs with respect to the 2% chlorhexidine and HAI. We had a visit earlier in 2025, and she did like on-site training in our hospital in order to train our nurses how to decolonize our patients correctly. Next. And here, if I will go very quickly through the trial, those trials started very earlier in 2023, in 2013, sorry. So for example, Climo et al. In 2013, he did 3 large randomized trial, including 9 academic adult ICUs covering 77,700 patients. Next, and they found a reduction in the bloodstream infection by 28%. Another study by Susan Huang team in 2013, among 43 hospitals, 74 adult ICUs, 74,000 patients. Also, they found 37% reduction in MRSA and 44% reduction in the bloodstream infection. However, they found that those reductions will never happen without a high compliance and adherence rate when it comes to the chlorhexidine decolonization. Next. In summary, chlorhexidine gluconate 2% found to be effective against MDRO, CLABSI, hospital-onset bacteremia, CAUTI, as well as SSIs, especially post-craniotomy and superficial SSIs. So now going back to our nurses and how those 2% chlorhexidine were applied and the method and the gaps that we found. Next, we found that the first challenge we faced among our nurses, the dilution. So the dilution of chlorhexidine, because we're using, I'm talking here about the 4% chlorhexidine dilution in order to prepare our 2% chlorhexidine wipes. Because I know that the 2% ready-made waterless wipe is not available in every single country. And many countries, they don't have the 2% ready-made wipes. And even if they have it, sometimes it will not be enough to universally decolonize every single patient every day. So we in Kuwait, we use the 4% chlorhexidine and we dilute into 2% in order to bathe our patient or to decolonize our patient. So the dilution should be 1:1. If you're using 1 cup of chlorhexidine, 4% should be diluted in 1 cup of water, 2 cups with 2 cups. So we found that the dilution was not proper, and usually the nurses will add more and more water, thinking that more water will make it more soapy. Next. Next. Next, also, not only this, it is how, when to apply the bathing. So chlorhexidine gluconate is not a soap. It is an antiseptic, so it gets inactivated with dirt. So the whole skin should be cleaned before applying the 2% chlorhexidine. So if the nurse started to bathe her patient or decolonize her patient and found that the thigh are full of dirt, fecal materials, or urinary incontinence, this area first needs to be cleaned. And after that, the chlorhexidine gluconate need to be applied, because if you will apply the chlorhexidine directly on the skin, it will be deactivated with the dirt and the whole effect of the chlorhexidine will be removed. And the cloth that needs to be used to dip into the 2% diluted chlorhexidine solution should be a proper cloth, and to avoid the cotton roll or cotton cloth, because cotton loves chlorhexidine and it will bind with chlorhexidine, prevent it release into the skin. Moreover, I think all of you, you know that diagram, and that there is a pattern whenever you will decolonize your patient, and some nurses will be so shocked and surprised, how come with one wipe I will scrub my both patient upper arms, but because each cloth will be folded on itself twice, resulting in 8 different services, and using 8 different services you can cover more than one area on the body. So this is, I will not go over this, the pattern of when to start and when to end whenever you will decolonize, but this is a well-known diagram that whenever you want to decolonize any patient, you need between 6 to 8 cloth based on the patient BMIs, and this is the order of decolonization. Also, we found that many areas usually be missed: axilla, groin, beneath breast curve, beneath any bellies, and those areas should be scrubbed very carefully, and also let them air dry, because if those areas will not be dried and will be kept moist, especially axilla, it will turn into a rash and a moisture area for infection rather than protection. And one of the major issues that also we found, that the majority of the nurses will have 2 basins, one filled with the diluted chlorhexidine, another one with water. So whenever they will scrub the whole body with chlorhexidine, they will rinse the whole body with water, dealing with the chlorhexidine as if it is a soap. Again, chlorhexidine is not a soap, it's an antiseptic that needs to kept on the body for 24 hours. It binds to protein, and if it will be on the body, on the skin for 24 hours, it will provide protection, and it will end up by reduction in infection, specifically the BSI and acquisition of MDRO. So chlorhexidine should be on the skin, and whenever during day any nurse needs to clean that area due to incontinence or any other reasons, that area need to be re-scrubbed again with chlorhexidine, because the whole patient body should be covered with chlorhexidine for 24 hours. So those are just quickly go over the challenges. So what happened after in 2025? And this data relates only 3 hospitals, because as I mentioned, we started with time series, and this data relates to those hospitals that had more than 6 or 8 time points of intervention. So since during 2025, we found a huge reduction in our Candida auris acquisition rate compared to the previous 2 years. Next. And this arrow reflects the start of the decolonization protocol in a proper way, in a proper method. So since the decolonization was implemented in a proper technique, the reduction started immediately, and it was very fast and huge. This red arrow just showing the increase in the trend during the winter season. And again, because this is real data, and you all know during the winter season, the patient census is increasing and the load on our nurses is increasing. And the opposite side, there is no shift in the nurses patient ratio. So we found that the compliances to the bathing protocol started to be affected little bit during the winter season. But again, because the data was shared on timely basis, we were able to control it. Next. Our BSIs due to Candida auris also decreased dramatically in 2025. Next. Next. And our eclampsia rate also, as it's shown here, in 2025 compared to the previous years, had a significant reduction. Next. This graph, this is the last graph that I will present. It reflects, I presented earlier the amphotericin B resistant C. auris in the blood, and I told you that one of the challenges that auris can mutate and can acquire more resistance, not only to fluconazole, to amphotericin B as well. So also looking at this epicurve that showed the BSI cases C. auris, amphotericin B resistant, the number of amphotericin B resistant in the attribute to C. auris in the blood also decrease over year. So here, this is showing, can you go back just, John? Yeah, so here it's showing after the starting of the decolonization protocol in a very, like, I will not say aggressive, but in a very, very close monitoring, like even the number of BSI C. auris reported by our reference mycology lab to be amphotericin B resistant decreased immediately, and only one case was reported in August. Next. So is it done? Are we over it now, or what is next? So I think many more and more to do, because this is not the end, this is only the start. Next. So we should continue with continuous bathing, educating, training, as well as monitoring, because bathing is just like hand hygiene. Whenever you will turn your head, you will find the compliance is going down. And it is not as easy as I am describing the bathing. It is not at all. Patients are obese. Patients are on different invasive devices. Patients have oozy skin everywhere. Some patients have bleeding everywhere. Patients on ECMO. So decolonization is not something easy to apply every day on the proper steps and methods that we're looking at. So the whole idea is to close monitor the compliance to bathing. So what we did, and we're still doing this, that every day the team of the infection control will go to the ICU and will train the nurses on real patients, because we stopped training on mannequin or any artificial human being. So they go to the ICU and they select patients, and they ask the bedside nurse to start bathing those patients in order to train them. And if any patient was found to have any dirt on any area, the night shift nurse who gave bath to that patient will be messaged immediately and will be called for a meeting to understand why that patient area was not clean when she bathed them at that time. So with this prompt feedback, the sense of urgency increased, and the compliance itself, and changing the behavior, as John mentioned earlier, that his main challenge in 2025 is changing human behavior. I 100% agree with him. With the thing that will make our job is very difficult, because our job depends on others' surgeons, where my skill will reflect my attitude, my outcome. I will succeed just because others' behavior got changed. So how we will change other behavior? By raising the sense of urgency and by giving them immediate feedback on time, and to overcome the miscommunication through like leaders or heads. Next. Next. Communication is very important, and not only communication is important, also next. Timely sharing of the data is very important. Our data is like our gold and jewels. We need to show them on time. If I will keep my data until the end of the year, then I will go back to them to share it with them. It's useless. So data should be shared on time in order to understand the gap, in order to overcome the problem, and in order to understand the pattern of infection. And in the coming year, and this year, hopefully, we'll extend our project to look at the effect of chlorhexidine on bed sores, on SSIs, especially post-craniotomy, as well as perineal cleansing and its effect on cavity. In conclusion, accountability is very important. Everyone should feel accountable. If no accountability, it means no improvement. Raising the sense of urgency is very important, because we need to change personnel behavior. Monitoring the effectiveness using other KPIs like days on therapy, NICU mortality, length of stay is very important in order to look at the effect of reduction of infection on other outcomes in the hospital, and thus will let even other leaders and stakeholders more convinced in the reality of the reduction of infection and its effect on length of stay, use of antibiotic, and mortality, which is the end result that we're all aiming at. And thank you very much. I do apologize for the technical problem regarding the slides, but I hope that it was beneficial and helpful for you all. Thank you.
Areej, thank you very much. A really brilliant presentation with loads of content in there. And we've got absolutely tons of questions to try and get through. So we're going to delve straight into them if that's okay. I think a lot of people are interested in the work you were talking about, decolonization and the use of chlorhexidine. And there's a couple of questions in the Q&A around, in the UK certainly, we often have people who report allergies to chlorhexidine. So I think there's two questions around the use of CHG. The first is that, did you observe any allergies in patients to CHG? And if you did have patients who were allergic, Gail is asking what you use as an alternative for decolonization.
Thank you very much. So this is a very good question. At the beginning of our chlorhexidine decolonization in March, I raised this question to Susan Huang, and her reply was that very rarely they found a case of allergy back in the US. So since we started, as I mentioned, that chlorhexidine was used since years and years in the country. However, it wasn't in the proper dilution or technique, whatever. But since the start, earlier this year, in our ICUs until now, I kept my eye on every single dermatology consultation in the ICU in order to understand the impact on this decolonization, especially that it is non-rinse, that you will not apply water to rinse it off the skin, and as you said, the allergy. And no single dermatological issue was raised, and no single dermatological complaint was given or diagnosed by the dermatologist. And even though when sometimes the nurses will complain that after we apply the chlorhexidine, the axilla of the patient, it turned into rash, we will find that the reason was not the chlorhexidine itself. The reason was that patient was plethoric, highly sweaty, whatever, and the nurse, she didn't let the chlorhexidine to dry enough on that axilla before returning the shoulder to its place. So we'll leave it with the moist area, and any moist area will exacerbate the rash and the infection. But hopefully during this 12 months, since, or less than 12, since March 2025 until now, January 2026, we didn't report any single case with an allergy to chlorhexidine in the country.
Thanks, Areej. It's clear that you're right on top of everything that's going on in the hospital with the dermatology testing. John?
Yeah, thanks, Areej. I thought it was brilliant. Thank you very much. Completely echo everything that's going on in the chat with people saying thank you. It was really, really insightful and helpful for me, thinking about how I can apply some of these lessons that you've learned in a very different setting to my practice in London. I found the whole picture quite frightening in some ways, particularly that development from an initial picture of colonization through to developing those clinical impact and those serious infections, the candidemias, etc. And I think the UK is likely to follow that kind of trend over the coming years. So we need to really think about that and learn from that. But also quite encouraging, because you were able to show that even when you had a really high level of serious infections due to Candidozyma auris, you were able to turn the corner and quite dramatically reduce those in 2025. Just one question on that. So in 2025, you implemented a bundle of measures. You implemented rapid PCR in some of the labs. You kind of standardized the screening program in the ICUs. You moved away from chlorine to peracetic acid as a disinfectant and really focused on chlorhexidine bathing. I guess you'll never really know which of those interventions made most impact, but do you have a sense of which elements of the bundle were more likely to have most impact?
I think if the answer will be the chlorhexidine decolonization. Why? Because I know that it is a multidisciplinary work, and definitely you need to have a clean environment, rapid testing, good screening, and decolonization. But what I observed, that once the decolonization will be impaired, and we can tell because, as I mentioned, every day we go to the ICU and we bathe patient again. We train nurses on real patient. So once we'll found the patients turn to be dirtier, the rate of infection will go up. And once we will re-control the low compliance with the decolonization, the infection will go down. And when I say that patients sometimes are dirty, because during winter season, some of the nurses will be taking care of 2 patients. like we call it double assignment. And those patients, they don't have enough time during night to bathe two patients, especially if one patient is a new admission or very critical patient or collapsed, arrested, whatever. So what I found that once the monitoring and the compliance, monitoring the compliance of bathing goes down, infection will immediately goes up, and the opposite way around. So I think decolonization is very important, but on the top of it is changing people behavior. Because if even decolonization was done properly without that sense of urgency, without the prompt feedback, without meeting every single nurse that found to have a dirty patient, dirty environment, and deliver the impact to her immediately, sometimes to force her to change her behavior, also the effect will not be that rapid. So I think decolonization is one of the most significant intervention that we applied and contribute to the majority of the reduction of infection.
Thanks, Areej. If we can maybe just stick with decolonization, because there seems to be an awful lot of interest in the use of CHG. There's a question here around whether or not you think that decolonization with CHG reflects true eradication of the organism from the skin, or it's more of a kind of load suppression, so getting it down to maybe undetectable numbers. Do you have an opinion on whether or not you're completely eradicating C. auris using chlorhexidine on the body?
I'm not sure that I'm completely sure that the C. auris is eradicated, because the target of the decolonization is to minimize the bloodstream infection. This is my target, and decrease the number of acquisition as well. So I'm not sure that those patients are truly eradicated and they don't need any lifelong isolation in the future whenever they will be readmitted again. But what I'm sure of, that during the decolonization process, during the ICU, that decolonization is able to minimize the appearance of that C. auris in the blood, reducing the candidemia, reducing the invasive candidiasis, reducing the mortality and the risk of blindness among 3% of the population, as well as minimizing, as you said, like the load maybe in the lab. But Anna, I do believe, because of our experience, that it's not only the load in the lab or what's showing in the skin. I think the main indicator is the BSIs. Whenever your BSIs is reducing, it means that you are on the right path and whatever you're done is correct, because this clinical sample cannot be hidden, especially the blood. Urine, ETT, those are non-sterile samples. They might not reflect a huge improvement, but blood, septicemia among vulnerable population ended with death. This is something that cannot be hidden. And if this decolonization is enough to minimize those eclampsies due to C. auris, I'm more than happy with this.
Thanks, Areej.
Okay, so a couple of questions in on screening protocols and screening sites. I was really taken by your data on colonization. I'm not sure if it's even colonization, maybe contamination of hands of patients and palms. It's not something we often sample in this country, but it looked like if we were going to sample one single body site, the hands and the palms would actually be the diagnostically the best for picking up the carriers. So I wonder whether you could comment on the importance of including hands in a patient sampling approach.
To be honest, in my country still, we did not implement this including hands and palms, because the hands and palms issue was just raised by Susan Huang, and it is now initiated in the US, where the majority of the hospitals, as my knowledge, they are screening hands and palms because they found it's the most part of the body where it will show the auris. But I was so scared to start screening the hands and palms with this such high rate of C. auris at the beginning. So I've decided not to screen for the hand and palms now and to leave it at later stage. But what we focused on during the bathing, that we are always raising the alert of the nurse that when you come to the hands and feet, you need to clean those areas very carefully, and you need to go over all the palms and fingers and tip of fingers very carefully of the patient to make sure that those areas are kept clean. Because from our experience, also Susan Huang experience, like the most dirty part you will find in any patient is his neck, groin, as his hands and palms. So I don't have much experience with the hand and palms. This is only theory that I knew from them. But hopefully in the future, maybe this year or the next year, we will also apply to make sure that whatever we're eradicating is true, and we're not missing any other patients with positive C. auris.
Yeah, it's a great line of thinking, and I think I feel similarly about whether to implement screening patient hands and palms. I guess the question is it actual colonization or is it contamination? Have they touched their body and have transient colonization of the hands, or is it a true site of colonization? I guess that's something that can be borne out through a program of research. Anyway, back to you, Phil.
Thanks, John. Last question from me. Gareth asks, did you do any learning reviews for your BSI cases, and did you find any common themes when you looked into them?
Sorry, did we do any?
Did you kind of do any post-case review to look to see if there were any common themes in your BSIs?
Hopefully in the future, not at this stage, but hopefully in the future.
Okay, thanks, Areej.
Okay, so you mentioned at the start you didn't get the feeling that traditional standard IPC measures were effective, and the evidence suggested they weren't. Was there anything to do with PPE that you changed, personal protective equipment, or did that remain standardized throughout the approach? And if so, what type of PPE did you use to care for patients with C. auris?
We didn't change the PPE, to be honest, because since the start, since this is post-COVID or pre-COVID, it's the same PPE that we apply for any contact precaution, which is gown and gloves. And in Kuwait, it's not only when you enter the patient zone, it's when you enter the patient room. Even if it is contact transmission precaution, we do understand sometimes doctors are arguing with us, I'm not touching the patient, I'm not touching the devices, I'm only looking at the patient, I'm only smiling at the patient. But because of the people behavior, and because we know that they might touch, they might enter, so since the beginning, PPE is applied whenever patient under isolation, he needs to wear all like PPE needed for that type of transmission precaution. So there was no change in the way of PPE is applied, but I can tell you maybe there was more because of the sense of urgency went up, because now they can see our team every day in the ICU because we're meeting them very frequently. So maybe this indirectly affected their behavior and led them also more adherent to the PPE compared to before.
Thanks, Areej. We're going to have to leave the Q&A there because we've got a couple of slides just to run through before we finish. But Areej, a tremendous thank you. And there's lots of really positive comments in the chat. We hope you get a chance to read them. So a big thank you from me and John and IPC partners and from all the audience as well. Just to close, we've got a really interesting program of webinars to come over the next 12 months. Our next is on the 4th of February, where Dr. Alex Sunderman will be talking about genomic surveillance for IPC principles and practicalities. You can scan the QR code there and that will take you directly through to the registration link. I'm just going to carry on. That is our schedule for all of our coming journal clubs and insight webinars. And again, there's a QR code on there that you can scan to see all of the schedule. You can also see all of our recordings on our YouTube channel. Again, you can scan the QR code and that will take you all the way through to all the recordings that we've done for previous journal clubs and webinars. And this session will be recorded and added in the next couple of days. Finally, we're really grateful to the partnership that we have with the Infection Prevention Society and the Healthcare Infection Society as well. So if you would like to find out more about conferences, webinars and meetings on infection prevention, then you can use this QR code from the IPS to discover what's going on in infection prevention. And then finally, HIS would like to talk about promoting their next annual conference. I attended last year. It's a fantastic event and intend to do the same this year. It's held in London at the Royal College of Physicians between the 23rd and the 24th of June. Again, you can scan the QR code to check out delegate registration rates. And of course, there's an abstract submission and there are early bird discounts available as well. You can also join the Healthcare Infection Society if you'd like to become a member of HIS. There's some information there on pricing and also just a QR code that will take you directly through to join HIS if you're interested in becoming a member. So without further ado, that's it from IPC Partners. A big thank you to Areej once again, and we look forward to seeing you on the next webinar. Thank you all. Bye.